Greetings and welcome to EHA Unplugged, the official podcast channel of the European Hematology Association, EHA.
Hello, I am Isabel Olivera, a medical writer for the European Hematology Association, EHA. Welcome to this podcast on gene therapy for hemophilia. I have the pleasure to have here with me today Professor Frank Leebeek. Welcome, Professor Leebeek. Can you please introduce yourself?
Yes, I'm Frank Leebeek. I'm a hematologist at the Erasmus University Medical Center in Rotterdam. And I've been involved in gene therapy studies, and I've also treated patients with hemophilia for over the last 25 years.
It's a pleasure to have you with us. So, we are going to discuss today the possibilities of gene therapy for patients with hemophilia. Please, could you first provide an overview of how hemophilia affects a patient and how it is managed at the moment?
So, patients with hemophilia A or B have a shortage of coagulation factors, which makes them prone for bleeding. So, especially patients with severe hemophilia who do not have any factor VIII or factor IX in their blood have spontaneous bleeds in, for instance, joints or muscles, which is of course painful, reduces their range of motion, and also leads in the long term to severe disability because of hemophilia arthropathy. So that is the main challenge, is to reduce the long-term complications of hemophilia, and that is why we currently give coagulation factor concentrates to these individuals, which they infuse 2 to 3 times per week themselves.
And why is this coagulation factor replacement therapy not sufficient? Why is gene therapy an interesting option for hemophilia?
Now, despite the fact that these patients are treated with these coagulation factor concentrates, especially the patients with severe hemophilia, they still experience bleeding problems, because by giving the concentrates 2 or 3 times a week, you do not have the same level of factor in your blood during the whole period of treatment. And that makes them prone still to bleeding, and of course the number of bleeds have been reduced dramatically by these coagulation factor prophylaxis. But still about 3 to 4 bleedings occur every year in joints or muscles, which at the long term may reduce their ability to walk and to do sports. So it affects, and it still leads to hemophilia arthropathy, although not so severe as in the past. And of course, it also it's a burden for the patients, because they have to be treated and they have to infuse themselves with intravenous punctures every 2 to 3 days. And there are some new treatments having become available in the past years that are given subcutaneously for hemophilia A patients, but still it is a burden because they have to inject themselves every week or every 2 weeks. So there has been improvements over the years, but there's still a burden for the patient.
And how would gene therapy help these patients?
Gene therapy may be a solution for these patients. The idea of gene therapy is that you give a one-time infusion of a gene construct intravenously, a 30-minute infusion, and by infusing this compound, this genetic compound, you will end up with expression of the new injected gene in the liver, and thereby producing factor VIII or factor IX. So the idea in the beginning was that you, by the expression of factor VIII or factor IX, you increase the levels of factor VIII and factor IX from 0% in those severe patients to maybe 10, 20, or even normal levels of factor VIII and factor IX. And that was the aim of gene therapy before we started all the studies.
So there are many mutations leading to hemophilia A or B. How is gene therapy being done at the moment in these different cases?
Now it depends, of course, on the type of hemophilia. But let's say start with hemophilia B, because that was the first gene therapy that was developed. So you use an AAV vector, an adeno-associated virus vector, which actually serves as a transporter. So that is, let's say, a crippled virus, which don't make you sick anymore, but you uses the capacity of the virus, where the gene of interest is inserted in, to transport the gene into the target cell, in this case the hepatocyte in the liver, one of the liver cells which normally makes factor 9. In the patient with hemophilia, due to the gene defect, they don't produce factor 9, but by delivering a wild type factor 9 gene or a gene with a high specific encoding for a high specific activity mutant, for instance the factor 9 Padua variant, thereby you add the gene, and thereby the expression of factor 9 will occur in these individuals.
So if I understand correctly, you are not repairing the mutated endogenous copy.
No.
You are adding a healthy variant in another location.
Yes. So it remains episomally located, so it's not integrate or hardly integrates, but by being episomal located, it can be expressed and the factor 9 can be made.
Does the expression of the construct persist during the whole life of the patient? I mean, given that the construct is not integrated in the genome, how long does the effect of this gene therapy last?
Now, the idea was that it has a long-term effect, but it was not expected to last lifelong. And we know from the current studies, it depends whether it's factor 8 or factor 9 that is being treated. But we see that the levels in factor 8 patients, hemophilia A patients who are treated with gene therapy for factor 8 expression, you see that the levels of expression decrease over time. So, and we don't know exact the cause, but for hemophilia B, the situation is completely different, because factor 8 is normally not made in the liver cells, but in the endothelial cells, and factor 9 is normally made in the hepatocytes. So apparently this may be the cause, but this leads to long-term expression of factor 9, even for up to 8 to 10 years. And we don't know the long-term effects, because that's not yet reached that period.
Can you re-administer the same construct?
No, it's not possible to re-administer this. That's also a limitation of the AAV gene therapy. Also for patients with a first-time treatment, if you have antibodies against AAV that is used for gene therapy, then you are not eligible for all gene therapies. Some you can give gene therapy, but not for all. But if you have ever had an AAV gene therapy, you make so many antibodies that it's not possible to redose. But we hope, of course, by developing new types of vectors, maybe not only virus vectors, but also other vectors, that we can give those patients a second treatment. But that's the future. That's not possible right now. So redosing with an AAV is not possible. No.
So for the moment, the effect is transient?
Yeah. For some people, we see some patients, and that's also in the studies, the long-term studies that have been published recently, we see that in some patients it levels off to, let's say, 10 or 15%. It's not the 100% that they maybe have reached in the beginning, or the 50%. But so, and also that is unknown whether how long it will last, and so there are patients who may benefit longer than the 5 or 6 years, maybe even 10 years. We don't know yet. We don't know.
And for which cases are there gene products approved?
So for both hemophilia A and hemophilia B, there have been gene products approved. Not in all countries. The EMA and the FDA have approved 2 of the products, and there's one other product that has been approved in Canada also.
So, hemophilia patients are used to the standard treatment, which is coagulation factor replacement. What are the arguments in favor of undergoing gene therapy instead? What would be the advantages for these patients?
Now, I think the most, we've treated several patients in clinical studies, so I know the experience that patients have after having undergone gene therapy, and I can tell you that their life changes completely. They have been using factor 9 concentrates for many years, sometimes up to 30 years since the year that they were born. And now they are free from injections. Those frequent injections are not needed anymore. They don't have to take hemophilia into account in their daily life. They can do sports that they have never done before. And they don't have to take all kind of medication if they go on vacation, because they don't need it anymore. And the prophylaxis, which they had to administer themselves 2 or 3 times a week, is not needed anymore. So that changes a lot. In addition, we see that the number of bleeds, which were, as I mentioned before, 2 to 4 still, despite having these prophylactic coagulation factor concentrates, they are hardly seen after gene therapy, especially in those patients who have a high expression level of the factor. The risk of bleeding decreases dramatically, and most patients, even after years after gene therapy treatment, are still bleed-free. So that is an important advantage of this treatment.
But is it possible to give it to all patients?
It's been tested in not in all patients. For instance, in children, it has not been tested. There are very few women with severe hemophilia A and B, but also they have been excluded from trials. But also patients with liver function abnormalities, for instance due to chronic hepatitis C that they have attracted in the past, were not allowed to enter the study. So also for these patients in the coming years, it will not be possible to be treated with gene therapy. And there are also some patients that may not be suited for gene therapy. For instance, you can imagine if you have a patient who's not very compliant with his current treatment, may also not be so compliant after gene therapy. And there are some rules after gene therapy, for instance, that you visit the hospital frequently in the first few months after gene therapy, because sometimes liver function abnormalities can occur. And if you don't treat that immediately, you may lose expression of factor 8 or factor 9. So we have to make sure that patients are compliant with the regulations, that they are seen once or twice a week in the hospital for the first 3 months. And also, they have to abstain from alcohol, because that may also induce liver function abnormalities, and barrier contraception for a longer period of time. So those are things that patients have to be aware of before they start gene therapy.
And how limited is the access to gene therapy at the moment? How many patients are getting the treatment?
That's a good question. I'm not aware of course, of all patients that have been treated so far, but I think it's about 10 to 20 patients who have had commercially available gene therapy over the past 2 years. So despite the fact that it has been approved nearly 2 years ago for hemophilia A and more than 1 year ago for hemophilia B, only very few patients have been treated.
Is this because of the cost or safety concerns?
Now, there are several reasons, but of course, with these new drugs, safety is very important. So also within the national authorities have to also approve the drug. And then, of course, reimbursement is an important part of the process to having access to these medications. And drugs are very expensive. So gene therapy is very expensive. Of course, it replaces the also expensive coagulation factor concentrate. But the prices are still much higher than the cost of coagulation factor concentrates, and that limits the accessibility currently for many patients.
Of course, there are hemophilia A and hemophilia B patients. What are the results for each of these cases?
Yes, of course. If we make a distinction between hemophilia A and B, we see that, for instance, for hemophilia B, the long-term expression is now shown for at least 4 to 6 years. And then you have benefit of these new drugs or of this new therapy for many years already. For hemophilia A, we see factor VIII levels that are much higher. In the beginning, after, let's say, half a year after gene therapy, these levels may reach 50% of normal with the products that are now available. But you see after half a year after gene therapy that the levels decline. And after 3 years, then about 10 to 15% already of the patients are on prophylaxis again because the levels were so low that they had bleeding episodes. So for those individuals, there are also alternative treatments available currently, which require frequent administration, but you know that your levels will stay high.
And is it possible to think of a CRISPR-based strategy to repair the endogenous gene?
Yeah. There are many studies on gene therapy ongoing. There have already been many studies. Most of them are the AAV-based, as I mentioned before. So those are, let's say, the in vivo gene therapy. But also gene editing might definitely be an option for patients with hemophilia. And there are several preclinical studies already been performed. And they are not yet approved or in clinical studies, so we have to wait whether that is possible for hemophilia A and B patients. But it may be a possibility.
So for the moment, is it necessary that the access is restricted to only a few patients?
I think it depends. There are several reasons why also patients do not want to be treated. It's not only the doctors that decide, of course, it's a shared decision making, especially since it's a one-time treatment. So if you give someone a treatment with a new drug and he has to take it every week and he has side effects, then you can tell the patient to stop the drug and the side effect will disappear. Here, what you have is, for instance, with hemophilia A gene therapy, what we have seen also in patients that I've treated myself, is that they developed liver function abnormalities after the gene therapy was given. And these liver function abnormalities persisted for more than a year in some individuals, at a median time of, let's say, more than 200 days of abnormalities of liver function, which required also in many of these patients, in most patients actually, for long-term treatment with corticosteroids. So what I'm saying is, if you give a gene therapy, it's given and you cannot get it out of the patient anymore. So they have to live with the side effects. And then I'm talking about, let's say, mild side effects, but we don't know the safety at a long term. So gene therapy in the past, and those were other gene therapies, but have led to malignancy in a few individuals. That has not been described yet for AAV-based gene therapy in hemophilia, but there might be side effects at the long term that we don't know yet. So I think also patients are sometimes reluctant to get this new type of treatment and say, I have another choice. I have at least coagulation factor concentrates that I've used long term, or I have a monoclonal antibody that is currently used for hemophilia A, which also provides protection against bleeding, and they make the choice not to have gene therapy. But I think we have to discuss that closely and extensively with patients who are in favor of gene therapy or who want to have gene therapy, to explain to them what the benefits and what the risks are or the potential risks are, and to make a shared decision on who is being treated or not. And I think that it's not only the doctor, that's of course clear, who decides what type of treatment the patient gets, but it's also the patient himself in this case.
So as the technology improves and the results accumulate, maybe more patients will be willing to be treated with gene therapy.
Definitely, I think if there's more experience, there have been people in the trials that really wanted to have gene therapy, and they were standing in line, let's say, at the outpatient office. But there are also patients who are very reluctant and say, I'll wait and see what happens 5 years after gene therapy, and if it works fine, then I want to have gene therapy. And that's a good, maybe that's a very good approach for them. So it depends on the patient.
So in summary, what would be the takeaway message for the audience about recommending this therapy or not to hemophilia patients?
Yeah, I think that for patients with hemophilia B who are in need of coagulation factor concentrates because of frequent bleedings, they have the opportunity to get gene therapy, then if we have explained what the risk and benefits are, I think most of them will be suited for gene therapy, and they will have long-term expression and long-term effects of those treatments. For hemophilia A, I think it's difficult because if you know that a certain percentage of patients will need prophylaxis after, let's say, 4 or 5 years, then the benefit is only temporary. On the other hand, the patients that we've treated and who were successfully treated and have declining levels, they say, I'm so glad that I have gotten gene therapy because it changed my life. And I haven't thought about gene therapy for many years now. And if it returns, if the levels go down and I have to go on prophylaxis, I'll go on prophylaxis. But then at least I have been free of hemophilia and free of bleedings for so many years. So it's also depending on your expectations as a patient.
Is there anything else you would like to add for our audience?
Yes, I think we are looking at gene therapy for hemophilia patients. And why is gene therapy for hemophilia patients well suited? Because a little change in factor levels, let's say patients who have after gene therapy only 5% of factor 8 or factor 9 already have clinical benefit because they have less bleeding, and also they are not in need anymore of prophylaxis. So for those patients it's very attractive. It's also easy to measure. It's easy to measure factor 8 or factor 9, so we know very soon whether it's effective or not. So also hemophilia is, let's say, a kind of model for other gene therapies for inherited disorders in which you cannot measure the effect of gene therapy so easily. So I think the developments in hemophilia may benefit a lot of patients with inherited disorders, especially the monogenic disorders that that can be treated with gene therapy. And maybe it also helps us as a hemophilia society to also develop gene therapies for other chronic diseases for which currently no treatment is available.
So thank you very much, Professor Leebeek, for this enriching discussion, for your invaluable insights, and thank you everyone for joining in and listening.